Welcome. I'm Dr. Joseph Vassalotti. I am Chief Medical Officer of the National Kidney Foundation. I'm Clinical Associate Professor at Icahn School of Medicine at Mount Sinai in nephrology. I'm here to discuss helping your patients with chronic kidney disease. I'll turn now to talk about diabetes. I think what's new in diabetes and chronic kidney disease and diabetic kidney disease, particularly the target is the same. The hemoglobin A1C is generally going to be 7. That's to help prevent onset of albuminuria and progression of albuminuria. That also should help slow loss of kidney function over time from observational data. Metformin is still the first drug that is recommended to treat type 2 diabetes by the American Diabetes Association. And in 2016, metformin was recommended to be discontinued for patients because of the risk of lactic acidosis when the eGFR is less than 30. That's a difference between previous FDA guidance. So up to 30, it may be possible to continue the metformin for your CKD patients. What's really new is this new class of drugs called the SGLT-2 inhibitors, the sodium glucose cotransport inhibitors. There are 3 drugs that are approved now, canagliflozin, dapagliflozin, and empagliflozin, and their respective trials with those agents are the canagliflozin was the CANVAS program. For the dapagliflozin, it's the DECLARE trial, and for the empagliflozin, the EMPA-REG outcome study. All those trials have shown improvement in cardiovascular morbidity and mortality for patients with chronic kidney disease that were included in the trials. Patients with chronic kidney disease had similar benefit to other patients in the trials. And what's really exciting about these trials, secondary analyses of the trials have shown that the level of kidney function has been stabilized in patients and improved relative to the control. And that finding of improved kidney function really crosses all 3 drug types and all 3 studies. The other point I should make here is that the FDA currently does not approve the use of these agents or recommends they be avoided when the estimated GFR is less than 45, and that's true for all 3. So it's only going to be for patients with CKD who have an estimated GFR of 45 or higher. The other aspect of these drugs that's exciting for nephrologists is that they work on the kidney, they work on the proximal tubular, they have complex effects which include osmotic diuresis, which include tubular-glomerular feedback, so they reduce interglomerular pressure. So they are kind of like ACE inhibitors and angiotensin receptors are for blood pressure. These are for diabetes by reducing interglomerular pressure, and they have an interesting array of cardiovascular endpoints that are improved, surrogate endpoints, I would say, in terms not only of reducing hemoglobin A1C. In most of the trials, the reduction in the glucose or the hemoglobin A1C is relatively modest. 0.58 reduction percent was seen in one of the trials, so modestly effective anti-diabetes drugs, but drugs that also reduce weight between 1 and 2 kilograms in the trials. They reduce blood pressure, about 3 to 4 millimeters of mercury systolic blood pressure reduction, about 1 to 2 millimeters of mercury diastolic blood pressure reduction. There were also small improvements in the LDL and HDL lipid profile parameters. So a broad array of cardiovascular marker improvement. And for chronic kidney disease patients, heart failure admissions were markedly improved. So for a population with diabetic kidney disease, which is enriched for heart failure, these drugs are really exciting in that they address heart failure, they address the potential loss of kidney function over time, they address albuminuria and albuminuria onset and progression. Now these drugs do have side effects, so one of the things that we have to be mindful of is diabetic ketoacidosis. That's been mostly restricted, or I think entirely restricted to patients who are insulin treated with diabetes, so that's one consideration. Another consideration is that These drugs have been associated with amputation, at least one of them in one of the trials, and so it's going to be important to evaluate your patients for peripheral artery disease, and the patients who have a history of amputation will be important to consider them. And then these drugs have also been associated with genitourinary infections, so that will be a history or a risk that's important to consider when you decide whether your patient may benefit from one of these therapies or not. And then lastly, of course, because they're blood pressure medications, they may have effects on blood pressure that you need to consider for patients who have difficulty with relatively low blood pressure, for patients who have a history of falls or syncope, for patients who have a history of hemodynamic acute kidney injury. But of course, this is going to be similar to your intensive blood pressure target dynamic, in that the kind of patients that are appropriate for intensive blood pressure control might be a similar population that's appropriate for SGLT-2 inhibitors if they have type 2 diabetes. And that is an interesting update we have on the SGLT-2 inhibitors. The ADA, with their recent clinical practice guidelines from January of 2019, recommends SGLT-2 inhibitors be considered for patients for atherosclerotic cardiovascular disease who have a heart failure or at risk for heart failure after the metformin as the first-line therapy. And then, of course, the FDA also has recommended these agents be considered for patients with chronic kidney disease when the estimated GFR is 45 or higher. If for patients who have an estimated GFR of less than 45, GLP-1 receptor antagonists like liraglutide from the LEADER study may be something that's worth considering for your patients with low GFR who you're concerned are not appropriate for SGLT-2 inhibitors at this time. And then lastly, I should point out that tomorrow at the World Congress of Nephrology in Melbourne, Australia, there's going to be a presentation of the CREDENCE trial. It's actually going to be Monday, Australia time, but here on the East Coast, it will be Sunday night. And we may have more information from the CREDENCE trial about the safety of these drugs and the efficacy of these drugs at low levels of kidney function. And we also may have more information about the safety of these drugs, particularly with respect to amputation.